Good morning, everybody. My name is Matthias Costa. I'm a cerebrovascular fellow at Swedish Neurosciences in Seattle. I want to thank Professor McDowell and Swedish Neurosciences Institute, Seattle Science Foundation for helping us putting these sessions together. Today, we have the great pleasure of having Professor Brijinkji. He's a professor of radiology and neurosurgery at Mayo Clinic in Rochester, Minnesota, where he also trained his residency fellowship in diagnostic neuroradiology. His academic achievements are outstanding. His research focuses on large vessel occlusion for ischemic stroke, artificial intelligence in ischemic stroke and intracranial aneurysms, among other many topics and fields. He was involved in the publication of more than 500 manuscripts and is part of the board of many important journals of our field. I could go on and on the whole morning, but I don't really want to take Professor Brijinkji's time. So welcome. Thanks for joining us, and it's our pleasure to have you. You can share your screen.
All right. All right. So today I'm gonna speak about foraminal vein embolization for treatment of CSF-Venous fistulas. And I'm just going to provide a little bit of background and also just a few updates regarding how things have been going and some of the challenges. So before I talk about things, I just want to give a shout out to our team. We have an excellent team at Mayo that's been involved in the diagnosis and treatment of patients with spinal CSF leaks. It all started with this gentleman here, Dr. Bahram Mokri, who passed away a few years, unfortunately. But we just have a great neurology team, many neurosurgeons, and a great neuroradiology team that's heavily involved in myelography and everything to make sure that the patients get proper diagnoses, as well as neuro-ophthalmologists that can help manage the occasional ophthalmological symptoms from the disease. Just as a disclaimer, Onyx for this indication is off-label. As you all know, currently only on-label use for Onyx is pre-op brain AVM embo. These are my disclosures. So basically today I'm going to introduce the concept of CSF-Venous fistulas and SIH, describe how they were treated before 2020, talk about foraminal vein embolization, talk about some of the published results, and then review extradural spinal venous anatomy and just kind of show, like some of the little tips and tricks in terms of the endovascular navigation. So spontaneous intracranial hypotension, it's a disease that many in the neurosurgical community, neurological community have encountered. The epidemiology, typically middle-aged patients, 30 to 50 years old, more common in women, 2-to-1 ratio. Like any disease that involves connective tissues, it just seems to be that that's the case. The annual incidence of the disease, actually, from the group out in Cedars and our group, we're finding that the annual incidence is about 3 to 5 per 100,000 patients in really rigorous epidemiological studies. So just to give you an idea, though, like aneurysmal subarachnoid hemorrhage is about like 7 to 10 per 100,000 patients. So at centers where we are really good at diagnosing the disease, where we have a captive catchment area in terms of patients that live in Olmsted County or patients that live in Beverly Hills, we are seeing that the disease prevalence is much higher than previously thought. Clinical presentation of these patients, the most common presentation, orthostatic headaches. Basically, bad headaches standing up, they lie down, 30 minutes, it gets better. Now, headaches, a lot of times we say, oh, it's just a headache, take some Motrin, all that kind of stuff. But this is truly debilitating. You can imagine that if you're a worker, you're a farmer, as many of our patients are, you're doing lots of stuff standing up. If every single time you're standing up, you get an excruciating headache that goes away the second you lie down, that can be very, very disabling. In more extreme cases, patients can have gait disturbances, cognitive dysfunction, sensory neural hearing loss and tinnitus, and very, very extreme cases. We see 2 to 3 patients per year that have get flown over here for coma, and they have spontaneous intracranial hypotension. But like these things here, cognitive dysfunction and sensory neural hearing loss and tinnitus are actually fairly common manifestations of the disease. Let me know if you don't hear the audio here. This is the first time I've put this in a talk, but this is a patient that I saw and treated recently, and this is him describing his symptoms, and it just gives you a sense as to how disabling the disease was for him.
Yeah, we're not hearing it, but we have the subtitles.
Okay. So this just gives you a sense as to, I know you guys could just read the subtitles, but, I mean, it is a very painful disease. This guy's a business owner. He's responsible for lots of people, and he can't function because of the headaches, the brain fog, the memory loss, all that kind of stuff. And when you look at the MRI of most of these patients, you get a sense as to why this is all happening. So typical MRI findings in an SIH patient, you have your pituitary engorgement, you have some loss of ventricular CSF, you have engorgement of the dural venous sinuses, you have, like a facet of suprasellar cistern. So the optic nerves that are basically draping over the pituitary gland or the sella. Sometimes these patients can present with some, funny vision. Prepontine cisterns of face, mammalopontine distance. You should have a real clear distinction between the mammillary bodies and the pons. You don't see that here. Cerebellar tonsillar ectopia that can explain some of the, imbalance that we see in the patients. Subdural hematomas or hygromas. And then dense pachymeningeal enhancement. These are typical imaging findings. At least 1 or 2 of these are seen in like 90% of patients. I will say that there is a subset of patients that have SIH, they have the clinical disease, but they don't have the imaging findings. And these patients are patients that we do work up. It's a little harder to find things in them, but we have found many fistulas in patients with normal brain MRIs. So our diagnostic workup, basically, we do a whole spine MRI, do like a T2 through the whole spine. And the whole purpose of that MRI is to say yes or no, do they have an extradural fluid collection? So if they have an extradural fluid collection, like you see here, then what they have is a frank dural tear. So some osteophyte somewhere that tore through the dura, and the CSF is just leaking into that extradural space. These patients are not the patients I'm going to talk about today. These patients are patients that, you need to do like a CT myelogram to find out where the tear is, where the osteophyte is, and then have a surgeon repair the leak. A majority of patients do not have the extradural fluid collection. These patients have what's called a slow leak. And these patients are your patients that have CSF-Venous Fistulas. So if someone has the brain MRI findings or the clinical symptoms, and they have a normal spine MRI that shows no extradural fluid collection, these patients, we do the lateral decubitus digital subtraction myelography. It's a 2-day procedure. 1 day on the right side, 1 day on the left side. Each myelogram takes about 30 minutes. But the idea is to identify something called a CSF-Venous Fistula. So what is a CSF-Venous Fistula? So it's a direct connection between the intrathecal space or the nerve root sleeve and the paravertebral or vein in the neural foramen. Okay, and it was only described in 2014 by Wouter Scheivink over at Cedar Sinai. I'll show you how under-recognized the diagnosis is. Oftentimes the patients report kind of like a sudden onset of symptoms. I was lifting something, I was like turning a bolt or a nut that was really stuck, and I was like pushing down and with the wrench and got it. I was lifting something heavy, etc. But the mechanism is still unclear. But based off the Valsalva induced mechanism, I think that there must be some tear or disruption in like the nerve root diverticulum, that happens with the Valsalva. That's what I think, but no one knows. So first description, as I said, 2014. The Cedar Sinai group looked at patients after they discovered the CSF-Venous fistulas. They looked at patients, from 2009 to 2015, and they found that CSF-Venous fistulas were 2.5% of spinal leaks. Then they looked at it in 2018, and they found that CSF-Venous fistulas were actually 23% of CSF leaks because they got better at diagnosing them. Now we're finding that it's like over 70% of CSF leaks. And the reason why is because we have a tool that allows us to diagnose these much better than we could before. That's the digital subtraction myelogram. So before digital subtraction myelography, we were doing something called positive pressure MR myelography. We would put a needle in thecal space, mix like 0.1 cc of GAD with like 20, 30, 40 cc's of saline, inject it. Okay, and the idea is to pressurize the patient to provoke the leak. So in peripheral IR, what they do if there's a GI bleed and they don't know exactly where it is, they'll try to provoke the bleed by injecting a little TPA to find where the extrav is. But this is kind of the same thing. Provoke the leak by injecting a little more saline into the fecal space. And a lot of times they're doing it with intracranial pressure monitoring, things like that. Well, the diagnostic yield for this super extensive procedure where a patient was under general anesthesia and getting MRI scans for 4 hours in the MRI scanner was 14%. So 1 in 7 patients were able to diagnose where the leak was. Okay, so not good, but that was like the best that anybody could do. And if you couldn't diagnose it, you do blood patch and hope for the best. CT myelography, which is fairly ubiquitous in the literature, the diagnostic yield, at least at our center, was low. It was like 7%. Okay, so basically, these scans lack the temporal resolution and sometimes even the spatial resolution to confidently diagnose CSF-Venous fistulas. So digital subtraction myelography is something that I learned how to do when I did my INR fellowship in Toronto, and it was by accident. We weren't like supposed to do myelograms, but there was a neurointerventionist there named Richard Farb who was doing them occasionally, and he taught me how to do them. But basically, it's a 2-day procedure. You do 1 day with the patient on the right side down, 1 day on the left side down. You have them on a biplane. It doesn't have to be biplane, but we use our Phillips machine and we tilt them about 10 degrees, and then we inject the contrast and watch as the contrast goes through each foramen and see does it escape at any location. And this article here is open access, anybody can access it, describes a lot of the tips and tricks. And we've had visitors come here to see our practice and learn how to do them as well. Sometimes you want to see a couple before you do it, and I think we're always welcoming people here. So here is a CSF-Venous fistula on digital subtraction myelography. This is a glaringly positive case. Not all of them look like this, but just shows proves the point. So just to give you a little sense, the patient's right lateral decubitus, here we have contrast that's layering in the thecal space, and it's here in this nerve root sleeve. So this is something you see a lot of times in these patients. That's just a nerve root diverticulum, not a leak. A lot of the leaking patients have multiple of these, but what you're going to see now is how the contrast escapes into the vein. So just pay attention right here, and you see how the contrast is getting into this linear, but you see how it's going to this complex network of blood vessels and getting washed away. So this is your classic CSF-Venous Fistula, and that's what you're looking for. But again, like I said, a lot of times it's more subtle, and but this one's a nice example. Oh, and then you see at the end of the myelogram, actually, see how the level below, the patient also had a little diverticulum there, but that's not where the fistula was. It was over here. So this is, expected finding in many of these leak patients, but this is not what you treat. You treat the fistula. So the diagnostic yield in patients that had, brain MRI findings of spinal CSF hypotension was 70% with digital subtraction myelography in our series. That was our early experience. So we're getting better and better at finding them and identifying them. And, someday someone's going to find a better way to diagnose these than digital subtraction myelography. But like right now, this is the best that we have. And that's what I tell the patients where we can't find the leak. I say, look, unfortunately, this is the best we have. We can do everything else. We can do the CT, we can do the MRI. This is the best we have. We can't find the leak, but maybe in a year or two we'll have something better, or maybe we'll get better with the myelography. I don't know. The reason I'm talking a lot about this though, is because this is the hardest part. The hardest part is finding the site of the leak. The hardest part is not the treatment, and I'll get to the treatment now. So surgery is a very good option for these patients. Typically, surgery involves a little hemilaminectomy, and the surgeon goes and either clips the nerve root vein complex after assuring that there's not a Damkowitz there, of course, because most of these are in the lower thoracic spine. And then obliterates all the veins, so cautery of all the veins that are in the area. All of our patients before surgery were getting blood patches. Only one patient had improvement with blood patch. So CSF venous fistula patients do not do well with blood patch. Of the patients that underwent surgical nerve root ligation, 50% were headache free. About a quarter had 50% improvement. So surgery works. Now, anytime something involves headaches, people say, oh, headaches, placebo effect, etc. But with SIH, we have actual objective MRI findings. We have the brain sag. And of the patients that had post-op MRI, and I do post-op MRI in every one of my patients, over close to 80% had resolution of MRI findings. 7 had no change. So in these cases, it's not because surgery was failed. It might be they had other leaks, somewhere else. And then, surgery. So, patients, there's like local operative complications. And, when you sacrifice a nerve root at like T4, T5, T6, whatever, they can get some dermatomal pain, paresthesias, burning, etc. These are some pretty examples of CSF venous fistulas that Wouter had shared with me. And, I thank him for that. Blood patch, a lot of people like to talk about blood patch. For patients with CSF venous fistula with epidural blood patch or fibrin glue, efficacy rate is hit or miss. We see that 2.5 to 14% of patients get better. It takes a few treatments before patients are, get benefit lasting more than a few months. It's not, it's the easiest thing to do. If there's nothing else you can offer, then it's fair to offer it. But I think that going with definitive treatments for CSF-venous fistulas like surgery or embolization is probably the preferred route. And I'll talk about embolization next. So, could there be a better way, right? And maybe many of you have seen this story before and are sick of hearing it, but I have to say it. Okay, so like I was reviewing a lot of these myelograms as part of like the research project, looking at the diagnostic yield of the myelography. And this one here was just this beautiful case where there was a huge vein getting opacified by the CSF-venous fistula. So there's all these complex like veins here in the foramen or right T2, and then it dumps into this huge vein. So it got me thinking, can you get into this huge vein, navigate into there and embolize it with the Onyx? Found any books on spinal vascular anatomy that I could, picked up this one on spinal flipography from the 1970s. And it was a technique that was used to diagnose disc herniations based off of like displacement of epidural veins. And you can see here that they show how to get into like veins in the lumbar spine, as well as veins in the cervical spine to diagnose, disc herniations at cervical and thoracic levels. Now, most CSF-venous fistulas are in the thoracic spine, but, just you open up Netter and you see that, a lot of these veins are coming off the azygos vein. The intercostal veins are coming off the azygos vein. So I said, oh, well, it can't be that hard to get in the azygos vein and get into this intercostal vein, and we can figure things out from there. So, I pitched to my surgical colleague that was treating all these patients, John Atkinson, to do azygos vein catheterization, venography, selective catheterization of paraspinal veins, to get in there and then embolize the veins with Onyx. And I'll go over the anatomy here so that's clear to you in a little bit. So, we found a willing patient that was willing to give it a shot. Our surgeons were on board. I said, you know what, if it doesn't work, at least you're going to have a beautiful fiducial that you can use, for surgery. Because, sometimes counting the thoracic levels intraoperatively is challenging. And actually at Mayo, we put gold seeds into the pedicle where the fistula is, for the surgeon, for cases where, surgery is being done, whether it's for like a thoracic meningioma or a CSF leak or whatever. So the anatomy, this is an AP view, this is a lateral view. So on the AP, dark blue is the azygos vein. Light green is the paraspinal vein. So this is the vein running along the lateral margin of the vertebral body. Dark green is the vein in the foramen or the foraminal vein. And you can see here that there's like this circle right here. So this is actually the nerve root goes through that circle. So this is like the venous plexus that goes around the nerve root. And then this here also envelops the nerve root. So basically, the CSF fistula occurs somewhere here. Either in the lateral epidural space, the foraminal vein, or in this little donut thing, plexus here, okay? So the foraminal vein, and then this is the lateral epidural venous plexus. So when I embolize, I like to get this lateral epidural, some paraspinal, foramen, this stuff here, and maybe a little bit coming in and out to block off all the ways of venous egress. So let's see here. So this is a video of treatment. Let's see if I can get that to play. Here we go. So this is a patient where we're doing the embolization. So this is the trachea, right main stem, left main stem. Above the right main stem bronchus, there is like this double density, and this double density here is the azygos vein, or like the valves of the azygos vein. So typically, what you do here is you get your catheter up, hockey stick shaped catheter, turn it posteriorly, and then advance the wire and try to get it to go across the midline in the azygos vein. So here, let me just play that. So here you can see the azygos vein. I'm advancing the wire, and it's going across midline now, just left of midline, and it's in the azygous vein. And that's, once you're in the azygous vein, you can get anywhere. So then I advanced my, vertebral catheter. Then I use like the benchmark. I just use the 6 French system. Typically I do all these femoral. My colleague at Mayo Jacksonville has been doing them radial, using a Simmons 2 to get in there, but I haven't done that yet. Then you do your venogram, and I showed you the anatomy earlier. And then basically try to advance your microcatheter into that paraspinal vein. Now, I've been doing these cases awake, so that's why I don't have beautiful video roadmaps. But like 80% of the cases are done awake. And the patients are fine. So here I'm advancing my microcatheter into that paraspinal vein. And you can see the tip of the microcatheter here. The wire is going medial, so that's the pedicle. So the wire is now going medial into the pedicle, underneath the pedicle. So that's the tip of my microcatheter, and it's right here. That's where the tip of the microcatheter is. So right by that donut, here it is on the lateral, and that's where it is in relation to the donut. So that I like to be like right next to the donut with, if I'm going to use a balloon catheter. And then you do the venogram to confirm that you're in a good location, that there's no little perforation or whatever. And then basically to avoid reflux into the azygous vein, sometimes I use a balloon catheter, and then just slowly inject the Onyx and have it kind of fill, the whole foramen, epidural space, etc. So, here's that patient that I showed earlier for the embolization. This is their CSF fistula. You can see this is a nerve root diverticulum, line in, line up. There it is right there. Here it is again, just different, inverted colors. That's the venogram on the patient. So this is, the CSF fistula. This is showing you definitely there's a vein that matches exactly what that myelogram is showing. And this is the Onyx cast. So this is how I like the Onyx cast to look. I like to have it epidural, underneath the pedicle, in the foramen, around the nerve root, a little bit above, a little bit below, a little bit above, and then some stuff coming in and out. This is what it looks like on CT. So this is like perfect. I have all the veins in the foramen obliterated, some paraspinal, a little bit intraosseous, no big deal. Here it is on the lateral. So that's the ideal Onyx cast. So we published our first series. You can see our first patient actually had 2 fistulas, and that gets to an important point that I'll talk about a little bit later. Our index series of 5 patients had complete resolution of signs and symptoms and radiographic findings in 4 out of 5 patients, partial improvement in 1 out of 5 patients. Here's one of our patients, subtle CSF fistula, but like this linear stuff past the nerve root diverticulum should not be there. Initial brain MRI, they had a pituitary cyst also, incidental. But post-op brain MRI, you see how the brain sag resolves. Pons resumes its normal shape. Pachymeningeal enhancement resolved. Just one little thing about this patient, you can see that their calvarium is a little bit thick. Patients that have the disease for a long time, they actually get calvarial hyperostosis, and that does create some issues after surgical or endovascular treatment, because you can imagine when the brain's trying to float back up, some of that space has been replaced by bone. So some of these patients can get like pretty wicked rebound intracranial hypertension that requires medical management. I'll talk about that a little bit. Here's another patient, nice example, CSF fistula, decreased suprasellar cistern, mammopontine distance, prepontine cistern, pachymeningeal enhancement, embolization, complete resolution of brain MRI findings. This patient didn't have symptoms as long. You can see they do not have calvarial hyperostosis. Updated series in JNIS, first 40 patients, mean age 57, female to male ratio was 29:11. This is a typo, so it's female to male. HIT 6 score, marker of headache severity, 36 is the lowest, 78 I think is the highest, or 72 maybe. dropped from 67 to 41. So big meaningful difference. And they say a meaningful difference for drop in HIT 6 is like 4 points. And we saw a drop in like 26 points. Median patient global impression of change was 1. So that means that, a majority of patients said that they were very much improved after the treatment. 90% of patients reported improvement. Burn SIH score, objective measure of headache or severity of brain sag, dropped from 5.7 to 1.3. Minor complications, local site pain where the Onyx is, very common. Rebound intracranial hypertension, fairly common. It's just a function of closing the leak. And I'll talk about that in a little bit. And then tiny onyx emboli that a little bit of onyx refluxes into the azygous vein and flies into the lung. You're talking like 0.1 cc going into a tiny subsegmental pulmonary artery of, no consequence. Majority of them are on the right side, right lower thoracic. That's actually a good thing. It's actually easier to get into these than any other of the levels. Regarding symptomatic improvement, headaches, vast majority of patients had resolution or improvement in headaches. Same with vestibulocochlear symptoms, cognitive dysfunction, and imbalance. This is just a marker of like burn score. You can see some of our patients had like no brain sag, so you're not going to expect them to have any improvement in their burn score. Some of our patients had like no headache, and you're not going to expect them to have any improvement. But you can see that, the trend is that everyone or majority of patients are getting better. Occasionally patients do get worse. That's from the rebound high pressure that they experience. And then this is just the number of patients that reported improvement. So improvement is 1 to 3, 4 is no difference. Worsening is 5 to 7. So just a little brief overview of some of the anatomy. I'm not going to go into too much detail because it takes a lot, and it's hard to show anatomy on PowerPoint, I think. But this is an article. It's open access on AJNR. So it shows basically we've explained how to get to every single neural foramen in the body, this is something that has applications beyond CSF-Venous Fistula embolization. This can help you potentially with like spinal cord AVMs. So I know Renee Chapeau showed a few cases at the Val d'Isere meeting where he actually did transvenous embolization of spinal cord AVMs, using this kind of navigation. It's very useful in epidural arteriovenous fistulas. I know a lot of times we like to go transarterial and embolize through the feeder, but like you can actually navigate into the venous pouch, using some of these tips and tricks. And if you get in the venous pouch, you can just crush the fistula and not have to, be as patient as you do with a transarterial embolization. Some ideas. So, like the veins that we're embolizing, just so, a little reference, they're not the spinal cord veins. They are not extrinsic veins along the surface of the spinal cord. We're basically extradural paraspinal. People have asked, do you ever see Onyx go intrathecal? Because there is a CSF-Venous Fistula connection. I've never seen Onyx in the subarachnoid space. And I've never seen Onyx in an intradural vein. And I think the reason why is that the veins have so much capacitance, and Onyx is going to take the path of least resistance. So it's very hard, it'd be very difficult to push Onyx into an intradural vein or through the actual site of the CSF-Venous Fistula, especially because that connection is so tiny. Again, just a nice graphical illustration in the thoracic spine. What are we doing? We're getting in the paraspinal vein. And then on the venogram, you always see the intercostal vein going out. And then there's a vein, there's 2 veins that go down. The far lateral one is an intersegmental vein that's going to take you to the level below, which can be helpful if sometimes I have trouble getting into T8 for whatever reason. So I go T7 and try to do, if I at least get in here, I can at least push the Onyx, into T8. But the vein that you want is, right next to the pedicle. It goes straight down Just like in an arteriogram, go straight down and then medial. This is your target. So you want to get that vein in the foramen, this thing, a little bit of this thing, and some epidural. That's just another illustration. So, you know, this is an anatomy that you see in like Netter and stuff like that. But basically, you know, we have, you know, your common iliac vein, your IVC, your SVC, your azygos vein. From your azygos vein, you can get into T5, 6, right? T5, 6, 7, 8, 9, 10, 11, 12. You can even get into the lumbar ones, you know, through there. For the lumbar ones, there's veins coming off the common iliac veins called the ascending lumbar veins that your wire wants to go up every time. So it's very easy to get into. So you can access any of the lumbar ones from these ascending lumbar veins. The left mid-thoracic, you have to go into the accessory hemiazygos vein, which is not that difficult, but that comes off the azygos vein. The left lower thoracic, those, you know, the azygos vein bifurcates, and you can just access that, you know, through the azygos vein or the hemiazygos vein. The hardest ones are the cervical and upper thoracic. You know, I don't want to go in the weeds too much, but I used to try to get into this supreme or superior intercostal vein on the left or right for these high thoracic ones, and then like get into, you know, the veins, and it was doable. However, there's an easier route, and you know, this is a pain. So there's an easier route, and I'll show you what that entails in a second. So the cervical spine ones, they come off the vertebral veins. So you have bilateral internal jugular veins, right? And, you know, sometimes when you're doing like an IIH stent or something, you're getting your wire up the IJs. And sometimes, you know, I just push the wire, and, you know, sometimes it goes like medial towards the vertebral body. And when it does that, it's actually in the vertebral vein. And the vertebral vein is how you get into all the cervical foraminal veins and also into the cervical epidural plexus. That's actually, you know, can be used as a highway to get into the upper thoracic spine. I'll show that momentarily. So again, here's our vertebral vein, and we have this rich anastomotic plexus in the cervical spine that's just, you know, very capacious, lots of routes to get into the neural foramina and lots of routes to get into the epidural space. So here, I'm going to show, let me go to the next one, you know, how I use the cervical epidural plexus to get into a fistula at like right T2. And this is like, these are like the hardest cases. So I'm just showing you, you know, this because it took me a while to figure it out. And now that I've figured it out, I don't want anybody wasting their time trying to get into the superior intercostal vein. And this is like 10% of patients. So it's not like all of them. Most of them are the azygos, very straightforward. But, you know, surgery is not an option for the cervical spine ones or T1 because, you know, they're, you know, obviously you can't obliterate all the veins surgically. And those nerves obviously have very important functions. So embolization is a great option for those patients. So here I'm getting my catheter in the vertebral vein that goes medial, right? You see, I'm basically, my wire is like already in the epidural plexus. Do the venogram. So the venogram here shows the vertebral vein. And then this faint stuff here is the cervical epidural plexus. And I'm trying to treat a fistula at right T2. So now I'm advancing my wire and I'm trying to get into the cervical epidural space. So finally I made it. I'm under the pedicle. You'll see right here. So I made it, right? I'm under the pedicle. Now I'm medial to the pedicle. And the cervical epidural space is like, it's a highway, it's massive. So the wire really easily can navigate down, and I'm able to get my wire out of the foramen at T2 with the headway duo here, do the microcatheter injection, little bubble, shouldn't have done that, but do the little injection and then proceed with the Onyx embolization, you know, from T2. So you can imagine For anything in the cervical spine, in the upper thoracic spine, you access it through the vertebral vein. So that's just like a real good pearl, because the supreme intercostal vein is very challenging to get into, and this is as challenging to get into as an internal jugular vein. And then proceed with the onyx embolization. I know what many of you are thinking. There's lots of stuff epidural. Is that safe? Answer is yes. You think about it, if you're using 1 to 2 vials of Onyx per case, you're putting 1 to 2 cc's of Onyx, in a very diffuse area. And Onyx doesn't get really hard, so like I have not had any patients get any compressive symptoms. I was worried the first time that I got lots of epidural, but I've learned, that it's not that big of a deal. So now challenges, right? So there are challenges to the treatment of this disease. Rebound hypertension is fairly common. I'd say 20% of my patients get rebound hypertension. So what happens? Your first patient that you're going to treat, they're going to tell you that the night the night after that they got treated, they could not lie down. They had to sleep on a couple pillows, and maybe when they got up and walked around, they started feeling better. If you think about it, patients had a leak for 6 months, 1 year, 5 years, 10 years, and their choroid plexus is trying to catch up with all of the leak, right? Like you're leaking, so choroid plexus producing CSF really fast. Now you close the leak, but there's some loss of autoregulation that must be occurring in some patients, and it's worse the longer the patients had the disease. So in some patients, it's very common that the patient has a little bit of high pressure for a couple of days afterwards, okay? But in some cases, it's so bad that you have to start Diamox. So now, if patients had it for like more than a few months, I give them Diamox. Our neurologist gives them Diamox. We say, here's 500 BID. If you start experiencing headaches while lying down, the reverse of what you had, start taking the Diamox. Some cases, like specifically patients that have like bad hyperostosis, it can get really bad. And patients can get papilledema. So I had follow up on a patient the other day that, we treated her. She had a leak for several years, and she got like grade 3 papilledema. We put her on 2,000 Diamox BID. Eventually, over the course of a few months, we were able to taper down to 0, and the papilledema is gone. Some cases, I've done venous stenting to get rid of that high pressure. And then some cases, I've had 2 cases now where venous stenting, even that failed. Patients had grade 4 papilledema. We had to put a shunt in. These are patients that have had the disease for a long time. I can't predict who's going to have it and who's not, with exception of like, I just know that patients that have had it for a long time, that had that calvarial hyperostosis, are more likely going to have it. 10% of patients, 5 to 10% of patients have bilateral chronic subdural hematomas as well. These patients, I've been doing MMA embolization at the same time as the CSF leak embolization, resolution of subdural hematomas in all those patients. If you see chronic subdural hematoma with pachymeningeal enhancement, and a patient that endorsed a history of orthostatic headaches, they have a CSF leak that probably caused the hematoma. And usually these are symmetric subdural hematomas. But just embolizing a patient or even draining a patient without treating the leak doesn't benefit the patient, because the mechanism of the chronic subdural hematoma in this patient is different, right? It's because there's a paucity of CSF, and they're basically, kind of sumping they're sumping the blood, from the dura into that, potential space between the dura, right? Multiple leaks, 10 to 20% of patients have multiple leaks. So sometimes you realize it after you treat one leak and they don't get better, and you do a DSM and you find that they have a leak somewhere else. Sometimes, we've had patients, this happens, we were noticing this before. We were primarily doing surgery. Now we do primarily endovascular. Some patients have 3, 4, 5 leaks. If they have like 3 leaks or so, I'll treat all of them at once. But if they have more than that, I do kind of stage, because I don't know, if you shut down everything at once and they have all these leaks, are they going to get the bad rebound, high pressure? Like most of this stuff is, empirical, right? Like I don't, there's no level 1 data. There never will be, but, long-term leak patients, outcomes are so-so. I mean, you can stop the leak, the brain MRI will get better, but they might not get completely better. And I don't know why. Is it because they have a leak somewhere else? Is it because their meninges are hypersensitive, chronic leak stuff? The brain MRI gets a little bit better, but not all the way better. But you can imagine if you have that chronic brain sag for 5, 10, 20 years, which is sometimes what we're seeing, if you have that, you can imagine that the brain could get kind of stuck, right? Or like the brain stem gets like permanently deformed. I don't know if that's really happening, but it's conceivable. And then failed embolization. I've had some cases where, you do a DSM afterwards and you see the CSF-Venous Fistula coming out through the Onyx cast. What happens is that, the Onyx, remember Onyx, it's not very thrombogenic. So I think that what's happening is the Onyx is kind of, you get like the porcelainization of the vein, and you think that you've occluded the vein, but you haven't occluded the vein. There's still a little channel in there. So in those cases, if I can re-access the level, I try to re-access it. Otherwise, I'll treat the level above and below with embolization. And in those cases, like out of the 10 that I've done for that, like 9 out of 10 have gotten completely better. Occasionally we've had a couple of patients that just go get surgery, and some of them do well and some of them don't, but whatever. So future directions, we're working on a randomized controlled trial of endovascular versus at least blood patching. The reason why we want to target blood patching is because, I've had no issues with insurance coverage or anything. If you tell the insurance company, because it's a fact, the alternative is surgery, or you're going to have the patient get 20 blood patches and 20 myelograms and all that kind of stuff. I've had like only 2 peer-to-peers and treated like 150 patients. They say that's fine. Do the embolization. But like there's a perception that blood patching is standard of care. So if it is considered standard of care, I think a RCT versus blood patching would not be a bad idea. There's potential role of other liquid embolics. I think Phil has potential advantages because it's iodine based or iodine bound, so you can actually see through it for a myelogram, whereas Onyx is extremely radio opaque. And then, we have some people that are considering putting together a prospective multicenter registry. I know the sound doesn't work, but I'll just show, this is that patient that I had seen earlier. And what I want you to get from this is that this is what the follow-up is like on these patients. And this is why I say it's the most rewarding thing that I've done professionally, because you have taken a patient that is in a state of misery, and to be able to bring them, give them hope, and able to bring them back to their baseline, functional status, is something that is something that all of us enjoy. It's why we chose our profession. And this is something, it is, you know that if it worked within a day or two, because the CSF regenerates itself every 8 hours or whatever. So within a day or two, if it worked, because in the brain actually, I do 3-month MRI, but my colleague Tian Hun in Jacksonville does 1-day MRI, and he's noticed that brain sag actually improves within 1 day. So yeah, so I mean, this just gives you a sense as to how bad the disease can be, and what you can do to really help these patients. And the brain fog is something that gets a lot of patients when they can't think clearly. And you can imagine all the stuff we're learning about lymphatics and all that kind of stuff, and Alzheimer's. I mean, not having CSF is a bad thing, and it messes with your brain. It messes with how you can function your day-to-day life. So that's what I have to say. I'm sure there are questions, and I wanted to leave lots of time for questions.
Thank you very much, Professor. It was amazing, tremendous talk. So we have a lot of questions, and I will start with a few. A few of them you already spoke about, but we will just go over fast. So what percentage of spontaneous intracranial hypotension you think is due to CSF-Venous fistulas?
Yeah, so I will say that we get less and less of the fast leaks now, because those have been easy to find, and many places are diagnosing them fairly straightforward, and the surgery is straightforward and everything. So in our practice, I would say that 95% of them are CSF-Venous fistulas. However, I think that it's going to be, I think it's close to 70 to 80% of these leaks are due to CSF-Venous fistulas.
Okay. So regarding the embolization material you spoke about, but how much Onyx you use in general, and which Onyx? Yeah,
so typically use 2 vials of Onyx, so 2, they say it's 1.5 cc's. I've never gotten more than 1 cc out of it. So typically use 2 vials. And if I'm right where I need to be, I use the Onyx 34. If I'm basically in the foramen, sometimes it's hard. So if in those cases I do a little plug of the Onyx 34, and then I switch to 18 and push 18. But Onyx is like cooking. We don't, little this, little that, whatever works.
Yeah. So did you see this CSF-Venous fistulas only on the foraminal region? So you can see them in the ventral or posterior regions?
Yeah. So I've had a couple now that are in the ventral epidural venous plexus. So that's yeah. So for those cases, you have to get deep in that. You have to get in the ventral epidural plexus and basically obliterate that plexus, like you would for an epidural fistula, because that's where most of those things occur.
Okay. The positioning during the the diagnostic procedure are just lateral, right? You don't go ventral or?
No, typically we do lateral.
Okay. Do you think these fistulas can also happen in the cranial region?
That's a really good question. There's this dogma that a skull-based CSF leak does not cause brain sag. I've heard that said over and over, and I guess I've seen many skull base CSF leaks, and they don't have brain sag. Can you have a fistula in the skull base? I think it's possible. I can't. I mean, how can anybody say it's not possible, right?
Sure.
But I haven't found any in the absence of. I've had a couple patients that had like venous malformations around the skull base, and we've found a CSF-Venous Fistula associated with the venous malformation. But like, I haven't seen any like, in like the, like around like the marginal sinus or anywhere like that yet.
Okay. Did you find any kind of coexistence or any relationship of the fistulas with spine instability or some degenerative spine disease?
No, these are generally younger, healthier patients with healthy looking spines. I mean, the myelograms are, these beautiful myelograms with no disc herniations and nothing like that.
Okay.
And then instability, no. I mean, many patients end up getting like Chiari's and stuff, like Chiari decompressions, because they're thought to have Chiari's. But like, I mean, people don't know, right? But now we're learning more and more about this. So I'm seeing less and less patients that are getting a Chiari decompression for a spinal CSF leak.
Yeah.
But like, some of those patients can get a little bit of instability. So.
Yeah, I mean, many of those patients don't improve.
Yeah.
So some questions from the audience here. What contrast do you use for the digital myelography?
Omni 300. That's the best. First of all, like Omni 300 is like the only 300 that you can use intrathecal, I guess. That's only on label for it. And I would not use 240. I would not use 180. You want to use 300. You want to be able to see it very clearly.
Okay. Another question here. What do you do if you fail to find the leak and you have a high suspicion?
Yeah, that's so frustrating. We do high volume blood patch. Sometimes they get better. A lot of times they don't. You see them on the list. They're coming back every few months for a big blood patch. I mean, what else can we do? Some patients, like, pain rehab, and then just saying, like, and we'll bring them back for repeat DSM. I mean, I had one patient, 6 DSMs. Eventually, we found a fistula, and it was a hose. But because sometimes you don't catch it at the time of your myelogram. So unfortunately, there's just no better way yet. But someone will figure it out. Someone will figure out a better way to do it than DSM.
Where do you do your blood patching in those cases? Just low thoracic?
Basically it's like multiple needles and just empiric interlaminar. Anywhere where there's like a big diverticulum, just put the needle there, put as much as you can, and yeah.
Okay. Do you think the blood patch just works by compressing the veins?
I think that's it.
Okay.
If it works, right? Because I mean, come on, the blood resorbs and the vein reopens. I mean, and you saw how complex the venous plexus is. Like, if you compress a few veins in the foramen, like, the fistula can go on the epidural plexus, right? It can find anywhere, I mean, as long as there's a negative pressure, which there always will be, eventually it's going to stay open.
Okay. Those are my questions so far. Dr. McDougall, any comments? You're mute now. Dr. McDougall, you're mute.
I was going to say, just a beautiful presentation, and you just so beautifully present it and make the argument and anticipate the questions. I had a chicken and egg question though. Some of these people who have the high pressure afterwards, how many do you think people are presenting with originally with intracranial hypertension and create the leak, and then that was really the underlying problem all along?
Yeah, that's a good question. So I have a big IIH practice and everything, and the phenotype of the IIH patient is not the phenotype of the SIH patient. Our typical, our female, middle-aged, young female patient, fertile, BMI greater than 30, etc. These patients, we're talking BMI, like 26, 27. So your normal, American, they are, 30 to 60 years old, but they're not your typical IIH patient. However, I would say that I think that there is indeed a subset of patients that definitely have some sort of intracranial hypertension that probably was the start of this. Because, the bottom line is we don't know all the causes of idiopathic intracranial hypertension. Not all of them are patients that are 20 to 40, female obese. Some of them are men. Some of them are healthy young women. I mean, we don't, so I think there's a subset that definitely that's going on, but I don't think that's a majority of them.
Yeah, it's interesting sort of spectrum.
I have a question. Do you measure the flow rate of the fistula? I mean, there's any way to find a correlation between the flow rate, for example, and rebound hypertension after the treatment?
Yeah, that's a good question, and we're trying to figure that out. Now looking at all these fistulas, what's the angio architecture? Is there anything with the flow rate and the rebound high pressure? And is there anything with the flow rate and the the severity of the brain sag? But it's hard to measure the flow rate, I guess, on the myelogram. So.
Okay, and the one question from the UK here: do you do DSM for any cause of CSF leak, or just to look for CSF-Venous fistulas?
To look for the CSF-Venous fistula, occasionally we'll find like a little nerve root tear laterally, but that's I think a lot of things that were called nerve root tears before were actually just CSF-Venous fistulas. For the fast leak, for the ventral epidural fluid collection, do a CT myelogram, with their hips up, head down, and look for a ventral leak.
Okay, Dr. Susanto has a question. Please, Dr. Susanto, go ahead.
Hi, thank you. Thank you very much for the talk. Very, very illuminating. I agree with you. I'm a diagnostic neuroradiologist here at Swedish. Very frustrating when I can't find a leak. Tried actually a DSM once, but couldn't get the mask with patient moving so much with the breath hold. Do you use general anesthesia to do this each time, or do you do just instructions, breathing?
Yes. So typically we use, maybe a little bit of fentanyl for pain, but then instructions for breathing. Lots of coaching with the patient ahead of time. We've done some general anesthesia. Some patients, they won't get it unless you do general anesthesia. It's okay, but it's very hard to get it set up for general anesthesia with the patient positioning, the cubitus, the tube, all the lines. It's a pain. Now, Cedar's, I think, does most of theirs under general anesthesia, and they have like these beautiful, beautiful myelograms and everything. But the bottom line is, it's a lot of work, and it takes a very motivated anesthesia team to help you produce the best images. So, I rely on the patient motivation and the motivation of the neuroradiologist to produce the best images possible. And I find that with some coaching, patients can do pretty well. And this is one thing, that I want the audience to know. The hardest part is the diagnosis and getting the DSM set up and that technique. And you really need to find someone in neuroradiology that's going to be a champion for the digital subtraction myelography. Like, we have many people that are champions for it, and you need that. You need to really engage the whole team, and because otherwise, you could be doing, it's just the best way to move things forward. Having a good team, good teamwork.
Agreed completely. And my second follow-up question is, how do we visit if I want trying to garner support and enthusiasm from my neuroradiology colleague? How do we?
Yeah, just shoot me an email and we can
Okay.
arrange something. Yeah.
Thank you very much.
Okay. One more question for myself. Did you try any alternative access to the veins, like transjugular, for example?
I did transjugular once. It didn't really help. You know, I've done a couple transradial. My colleague at Mayo Jacksonville has done a lot transradial. That's fine too. You know, I mean, like I agree, like for like intracranial embo, like arterial stuff, you know, radial is, you know, we do a radial all the time. But like for vein, I mean, you know, it's a 1 hour of bed rest after you've embolized a CSF fistula. They're going to be lying flat anyways. And, you know, there's very little risk to a venous puncture with a 6 French sheath, you know, so and it's just more easy, like, you know, especially when you have your fellows and all that kind of stuff and you're all there.
Yeah.
Yeah.
Okay. So that's it. Thank you very much for your excellent presentation. It was illuminating for us. Tremendous talk. Really good.
Sounds good. Thanks so much for having me. I really appreciate it.
Thanks, Waleed. Great seeing you. Really appreciate it.
Thank you.
Bye.
Bye-bye.
Bye, Professor.
Bye-bye now.
Thanks.